So good afternoon, everybody. My name is Alberto Carli. I'm at HSS, and we're a little bit behind time, but hopefully we'll be able to account for all that hubris from all these approaches, because we're going to talk about what happens when something goes wrong. And now, instead of us thinking we all have a great solution, I don't think we necessarily have the right solution yet, but we've assembled a panel of experts to talk about this. So I'll go first about a possible option for treatment in case. I'll try to tell you what to do for irrigation solutions, do's and don'ts. I do, by way of disclosure, I do some education and counseling for Heraeus Medical. It makes Palico cement, but it's not really relevant to this talk. I get some research support from HSS. Infection is now the #1 reason for linked revisions in the American Joint Replacement Registry, so just an indicator of how this devastating complication is unfortunately not going away, and therefore we have to work really hard to try and fix it. Of course, the more total joints we're going to do, the more we're going to see infections. The sicker our patients are, the more we're going to see infections. And unfortunately, the gold standard, which is a 2-stage revision, is a fairly morbid surgery, and of course has been associated with substantial risks of mortality, blood loss, disability. And as you can see, imperfect success. You still have a relatively unacceptable rate of reinfection, or some patients who never actually get their definitive spacers. That doesn't mean that 2 stages don't work, and they still are the gold standard, but there's really been an interest to try and optimize DARE. And DARE, of course, which we'll get into in the next talk, is debridement, antibiotics, and implant retention procedures. We tend to do it more for acute infections or when patients can't tolerate large infections. The main principles, of course, we'll talk about in the next talk, but for the sake of time, I'm going to focus really on the idea of using an antiseptic adjuvant to really try and reduce the bioburden that is left in the joint after you've done your DARE. Now, using antiseptic solutions is not really a foreign concept to surgeons, but as you can see, the market has been flooded with a multitude of products, some which have been around for a very long time and cost pennies, and some that cost hundreds of dollars. So are they effective? Are they toxic? And what is the cost? But of course, why should we be using antiseptic solutions? Well, again, we've been using it for hundreds of years. Joseph Lister used carboxylic acid. We then had the Dakin's method in the World Wars and Dakin's solution, which we still use today. And then the simultaneous, if not serendipitous, discovery of chlorhexidine and povidone iodine in the 1950s, which is what we use today for prophylaxis. We, of course, know why we have to do this, because once bacteria or fungi get into the joint, they can then form this extracellular matrix called biofilm, which can adhere to everything. Can also be in our soft tissues. So we have to do something to try and decrease the contamination, which I would submit to you occurs in every surgery we do, either at the time of surgery or at some course post-operatively. In terms of what the literature shows, this is the study that really reenacted the interest with povidone iodine, at least in the modern era. This is Craig Della Valle's paper about 9 years ago, showing a 6-fold reduction in acute infections while using a dilute povidone iodine lavage. We then saw a very important paper from Jay Parvizi's group showing that polymyxin and bacitracin, the sort of holy water we tend to mix in with our normal saline, is not so effective, and that it doesn't really kill bacteria as well as other solutions. And then we also understand from this other excellent paper, which shows that we really can't mix and match any antiseptic solution we'd like. As you can see, if you mix chlorhexidine and Dakin's, or Dakin's and hydrogen peroxide, you can end up with toxic metabolites which can poison your patient. So just because they're effective doesn't mean we can just mix and match them. In terms of what the most recent papers have shown from the last 3 years since our last international consensus meeting, this is a paper again from Rush, Craig Della Valle's group, following up now in aseptic revisions, now showing that with dilute povidone iodine, that's sterile povidone iodine, and we can talk about that a little bit later on, they found again a significant reduction in infections in their aseptic revisions. Another paper from the Rothman group, and now a larger group, larger retrospective study, also showing a 2.5 lower PGI rate when you use this dilute povidone iodine. It's important to say, though, that not everyone has noticed a decrease. This is Kevin Perry's paper from the Mayo Clinic, both in primary and revision cases, and they actually found, at least in their primaries, a paradoxical increase in the use of infection, in the incidence of infections with dilute povidone iodine. And having visited them just recently, we can possibly understand that when your institutional infection rate is quite low, introducing a possible toxic solution into the wound may paradoxically increase your infection risk. So just some food for thought. I would be remiss if I didn't talk about these additional papers looking at vancomycin and dilute povidone iodine, the sort of VIP protocol, which now in 2 papers has been shown to have substantial risk reductions in infection in high-risk patients. This is a really good paper. This is hot off the press from Mark Spangel's group, where they actually looked at a variety of different irrigation solutions in vitro and actually applied them for different amounts of time. You can imagine arthroplasty surgeons, we're really impatient by nature, so leaving these things in for minutes and minutes is quite toxic to our idea in terms of trying to get on with our day. But this paper showed that you actually have to leave most of these solutions in for 90 seconds to have some sort of effect, at least in vitro, against common bacteria you see on the right. This is a paper that we published, got recognized last year, and then was published this year. We looked at porous titanium, cement, and plastic. This is an in vitro biofilm model looking at MSSA. And what we actually found, looking at a variety of different commercial products, is that in a planktonic state, that means really your contamination you have at the time of surgery, all the commercial products work pretty well. And it is important to see that polymyxin and bacitracin, which you can hopefully see if that's projecting up there, was not really effective, and vancomycin wasn't very effective. But again, vancomycin likely requires time to work more than just a few minutes, so that perhaps it's not really a fair comparison. But this is a biofilm model of 72 hours. That's mature biofilm that we have on the variety of surfaces. And what we found is that non-diluted povidone iodine, so you take it out of the bag, but you don't dilute it with any saline, was actually the most effective at decreasing biofilm. And basically the dotted lines you see there represent a 3-fold logarithmic reduction, so 1,000-fold in the number of CFUs. So we found that povidone iodine, with or without peroxide, was the best at reducing all of these on all of the surfaces. And just to show you, because people sometimes wonder, do you really use non-diluted povidone iodine? This is me in the OR a few weeks ago, taking the non-diluted povidone iodine right there, right out of the bag with the brushes, and actually using it to treat infection. You don't need to do this in your primaries, but I do this routinely in all of my infection surgeries, DARE 1-stage or 2-stage. So do's and don'ts. Do really consider using an antiseptic solution at the end of your primary revisions, especially in high-risk patients, and especially if your institution has a problem with infection. Do consider increasing the concentration in the setting of PJI. Don't rely on antiseptic solutions to make up for an inadequate debridement. Don't leave antiseptic solutions inside patients, and don't mix these products as they can form toxic metabolites. Thank you very much.